प्रेजेंटेशन में ओरिजिनल जब ये कोर्स स्टार्ट हुआ था तो वी वर स्लाइड शो हाँ ये क्या हो गया अच्छा ये इधर फोर्स पे आ गया ठीक है राइट अच्छा कंसेंट जो होता है तो ये मतलब दिस इज इन्फॉर्म्ड कंसेंट सो यू हैव टू हमारे मतलब डिफरेंट वो पार्ट ए पार्ट बी वगैरह वहाँ पे जो हम लोग स्टैंडर्ड यूज़ करते हैं तो यू हैव टू गिव द फुल एक्सप्लेनेशन ऑफ द प्रोसीजर all the risks complications are discussed with the patients including risk from throat spray down to risk from sedation the actual well-recognized complications like bleeding, perforation, pancreatitis in case of ERCP, and infection. So, normally we carry out a DOPS assessment on all our candidates. So the candidate is assessed for how they give out the procedural information to the patient, how their explanation is. Should be in simple terms, layman terms, without using medical jargon, because you have to make sure that the patient understands what you want to convey to him. And he should be able to assess and process that information before they agree to sign the consent for you. It's also important to assess their comorbidities because ERCP in a young fit person is very different from ERCP in an 89-year-old patient who has got diabetes, hypertension, ischemic heart disease, multiple comorbid factor, is on anticoagulants or antiplatelet factors. So they are very different, the whole. So the key components of an informed consent. The main principle of an informed consent is that the patient should have sufficient information to understand the procedure. It should be, as I said, explained in simple layman terms to them, its benefits and the harm that may come out of the procedure, which is the complications, the side effects. What is informed consent? Informed consent is when patient is able to understand and retain that information. Because when you ask him again, what did I tell you, or they should be able to tell you, or if suppose you take a consent from the patient and the patient's daughter comes and asks them, what did the doctor tell you? So that patient should be able to tell his or her daughter to what the doctor had just told him. He should also be in a position to weigh up the information, whether, what he makes of all the explanation that he's given him, the patient can understand that, well, if I don't have this procedure done, I might die from septicemia, but if I have this procedure carried out, there's a good chance that I can survive, but there's a very small chance I might end up with some sort of a complication which might be life-threatening. So they should be able to make their decision and communicate their wishes. So it is important that we make sure that this patient has got mental capacity. Mental capacity is when he's able to understand, retain, and process that information. So one should make sure that the patient has mental capacity. The other important thing is that the patient should not be forced to undergo the procedure. You should not emotionally or otherwise blackmail him कि नहीं जब तक ये नहीं कराया तो बस तुम मर जाओगे ये वो. You should give them ample you should give them full information and let them take the decision. Even if the patient refuses, and if the procedure is in the best interest of the patient, and if you refuses, you can't force them. Secondly, you should also offer them alternate procedures. What else is available? Whether, like if you are going to consent for a colonoscopy, they said, oh, can I have something else done which is less invasive? And you can say, well, you can have CT colonography carried out, but the limitations of CT colonography are this, and you can have a capsule colonoscopy carried out, which is nowadays very much in practice, but those are the limitations. You can't carry out if they find out polyps in the CT colonography or capsule colon examination, you still might need a colonoscopy to have those polyps removed. So you should be able to give them, and they have the right to refuse treatment. You can't tell them, and even if they give you a signed consent, the patient is still in a position to withdraw the consent anytime during the procedure. So if the patient says, I don't want to have it done, even if you are in the middle of the procedure, you should stop. You shouldn't do it. Otherwise, you could be accused or charged for assault. So that is important. Secondly, we never carry out a consent inside the procedure room. You should never do it, because that means you are putting them under pressure. Consent should be carried out in a separate room, in privacy, and in an environment where the patient is not under pressure. So during the consent process, you don't carry it out in public. So it should be in privacy. You should be sitting one-to-one. And normally I use the structured the acronym for the consent process, which is EMBRACE. What we do is, EMBRACE stands for E for explanation of the recommended procedure, motive or reasoning behind the medical procedure, B is for the benefits, why we are doing it, what would the outcome, if the patient has got cholangitis, ERCP can be a life-saving procedure for them. Risks or any complications or the effects are the any, like if they've got comorbidity factors that they might be more at risk of developing a heart attack or anything, so those risks. Alternatives, you give them the alternate procedure if they are available. Somebody who's got a rip-roaring cholangitis, there's not much of an alternative there, unfortunately, because you need a therapeutic procedure there. Complications, again, and then the side effects are effects of any medication that you use. Because when you are using conscious sedation or a general anesthesia or propofol anesthesia, you are exposing the patient to risk of those medications. Even when you use pharyngeal spray with lignocaine, some people are allergic to that and they might have an anaphylactic reaction. So all those come. Now, if the patient withdraws consent in the middle of the procedure, what do you do? नहीं, तो अंडर सेडेशन भी हो तो उसके मतलब प्रोसीजर वो है, क्योंकि ये कहना गलत है कि नहीं ये पेशेंट अंडर सेडेशन था, इसको पता नहीं था. You can't use that as an argument. If the patient says कि भाई stop the procedure, you are required to stop it, because you have no defense. Otherwise, if you accuse the patient कि नहीं ये झूठ बोल रहा था, so then you become liable of a criminal offense rather than a medical negligence. So they are entitled to refuse patient. So even you know that this procedure is life-saving for the patient, you still do not force it on them. So unsedated अगर patient हो, तो you just immediately stop. No argument, no nothing, don't do anything. क्योंकि end of the day it is the patient's responsibility and your responsibility to go. Sedated patient में ये होता है कि you must act in the patient's best interest. उसमें फिर ये बात होती है कि you have to see how much the patient is aware of what's going on. Secondly, you can do a certain maneuvers, like if you insufflated too much air, you suck out most of the air, you put the patient in a better position, you can tell them that, look, I'll give you a bit more sedation, that might make it more comfortable for you. Sometimes that would work, and perfectly reasonable to do that. And can give them more painkiller like fentanyl or pethidine or whatever you use. But if that doesn't work, then you must stop, even if they are sedated. Because if he says, and even if after you've carried out all the maneuvers and the patient says, so sorry, I don't want to have it done, then by all means stop. Yeah? Mm-hmm. Yes. So yes, you have to withdraw. Because there is no justification for you. A lot of the people stupidly carry on doing it, and then they are accused of, and that comes under assault or battery. So it is a more serious offense then, right? So it's always best to draw. You can always do it on another day, or another colleague can come and do it. Because most of our colonoscopies we do without sedation. Hardly any, very few of my patients require it. So if your technique, you can get somebody more experienced to do it for you, or even on a different day, it might be different for the patient, because sometimes if you've insufflated too much gas into the colon, it makes it very uncomfortable. Especially if you do OGD and colonoscopy on the same session, then colonoscopy becomes more challenging because most of the air tracks down to the colon, and it makes it more difficult for them, right? Important do's and don'ts of, so whenever you are doing any procedure, always make sure that you read the patient's notes, or look at all the investigation results, be familiar with the local consent form policies, and always introduce yourself to the patient, what you are doing. Use a structured approach to consent, like the EMBRACE acronym, and always check for the patient's understanding of the procedure, and also make sure that they've understood you. If they speak a different language, use an interpreter. Don't use family members for interpretation, because they can, it's not always reliable. So always make sure that if you can get hold of a proper certified interpreters, you make use of those. And secondly, like amongst the don'ts, don't forget to ensure privacy. Don't use too much medical jargon, because it might be second nature to you, but the patient might not understand what you are saying in medical language. And also, though you want to be thorough, you want to be complete, but don't take ages to carry out the consent. You should do it in such an structured approach that you are able to do all this in 5 minutes. Right, Haji, that's all for consent. Any questions?
One question,
Ji.
regarding the privacy.
Ji.
In our setup, usually we give complete information to the patient about the procedure. The procedure he conducted, risk, benefits.
Ji.
They call other family members, and he or she says, please tell my relatives
Yes, sir.
what you are going to do with me.
Yes, sir.
So, what we can take message from privacy?
No, that's a very good question. Because there you have the consent of the patient to convey that information to their relative, then that's fine. If the patient says, don't tell my daughter or daughter-in-law or son, then you are not supposed to tell them. But if the patient says, हाँ जी मुझे समझ नहीं आई, इनको ज़रा समझा देना, बाकी खैर है, so then in that case it's best to inform them, because then you've got the patient's consent there. जी हाँ नहीं वो तो ठीक है ना. If the patient says that to you, तो फिर तो you are fine ना. लेकिन अगर उसने ना कहा और आप उसके even बेटे को भी बता दें, तो even if you are going to tell about the patient's condition to their children, you have to have their consent.
ये जो रिसेप्शन पे बैठ के फॉर्म फिल करते हैं कि भाई ये तो फिर कंसेंट सेपरेट हो
नहीं, वो तो खैर देखें ये
हेलो, हाँ मुस्तफ़ा।
अगर
ये तो प्रॉपर वे नहीं हो रहा हमारा।
नहीं, वो तो ठीक है ना जी, लेकिन इसका मतलब ये तो नहीं है ना कि सारी उम्र तो यही करते रहे ना। लेकिन
ठीक है, मैं
ऑलवेज रूम फॉर इन्वेस्टिगेशन ना। अगर यही होता ना, जो अगर कहते हैं ना कि हम ऐसे ही करते हैं, तो आज हम सर्जिकल 4 के उसमें एंडोस्कोपी यूनिट में बैठे होते हैं, जहाँ पे हम पहले जहाँ से हमने शुरू किया था। नॉट दैट इट वाज बैड, बट यू हैव टू मेक इम्प्रूवमेंट। तो आज जो है तो इसी वजह से यू गॉट वन ऑफ द state of the art unit here, which one can be proud of internationally.
So one more thing, consent has to be at 2 point in time. Okay, it's not just the patient has come to me, I'll take the consent. If they're given the consent, it doesn't work. Ideally, the consent should be done. You should give some time for the patient to decide whether he wants to go through or not. So in majority of the cases, consent has to be, like even if you apply for a grant or you're doing some research, they'll ask you this question: how much time was given to the patient for decision making? Actually, if I tell you something right now and I ask you to take a decision on it, that might not be the correct decision, right? So it has to be done at least two times. The first consent should be at the first consultation, and the second should be on the day of.
I think this presentation, I must acknowledge is by Dr. Saad Niaz, but I'll present it on his behalf. So please bear with me, or I might change it according to my needs, but anyway. So, right, okay. So you can read what it is. It shows that it just stresses the importance of how important the limitations or challenges in ERCP are. Despite all the innovation improvement in techniques and the accessories and everything, there is still an expected failure rate of up to 20% in ERCP cannulation, which is very high. Normally, in BSG also, or according to JAG, our requirement is that the person who should be doing independent ERCP should have a cannulation rate of about 85%. People like myself, Sadnyas, Sarisha, Shanil, we all expect to achieve a cannulation of rate of 95 to 97%, because that is our, normally most of our cannulation rate is among that. But generally, we expect people to have the minimum requirement of 85%. So that is something which is very important. It is a challenging procedure and not easy to. Again, standard method for selective biliary cannulation, papillary assessment and positioning, that is the most important step in your procedure. The rest is, once you get that under your belt, the rest is slight adjustments here and there. So the most important thing is positioning. And positioning, it can be difficult at times. I mean, not every patient is the same. When you get to the papilla might be in the diverticulum, it might be twisted around in an odd way. There are different shapes and forms of papilla, which we probably will discuss. I've got a presentation on that as well, but we can see where it is. So now, I think it says standard methods of biliary cannulation include contrast-assisted cannulation and guide wire assisted. Nowadays, very few people do contrast-assisted cannulation. We all do guide wire assisted cannulation, right? So you only inject contrast when your guide wire is in position. You don't. In the past, we used to go with contrast injection, and you would end up injecting contrast submucosally or too much contrast in the pancreatic duct, and it would cause more complications. So it's always guide wire assisted cannulation followed by contrast injection. And you, as I said earlier, you only inject contrast when you got fluoroscopy on. Don't inject contrast before, because you don't know where it all ends up. So always inject small quantities. In the past, because I've been doing, believe it or not, ERCPs since 1990, before some of you were born. So we started ERCPs with fiber optic scopes. We would never use a sphincterotome to cannulate. We would always go with a cannula, cannulate, inject contrast. There were no guide wires. Come out after the initial cannulation. If there were stones, we would cannulate again with a sphincterotome with no guide wire, and then do a sphincterotomy. If we had to put a stent in, we would cannulate with a diagnostic ERCP scope, do a sphincterotomy if there was a stricture there, take the whole scope and everything out, and use a bigger therapeutic ERCP scope and do a stenting after that, which was a very tedious process, and obviously you would fail in one or the other steps, but that was how it was done. Guide wire, sphincterotome, all these are new innovations over the years. So with the sphincterotome, the advantage is, with cannula, it's only a fixed angle, it's just round. And if you had a new cannula, you would always try and twist it with around your finger to give it an angle. With the sphincterotome, you got the luxury of adjusting the angulation of it. Most of the time, its own tone is enough to do it. You don't have to angulate it, but that's how we do it. So, right. Right. Normally, we use a hydrophilic guide wire because they are nice, slippery, and achieve the duct selection without injection of contrast. Guide wires with angle tips have been shown to lead to shorter cannulation time. I mean, it's a matter of choice. Usually, the first cannulation, I just use a straight wire, It doesn't make much difference. If you've got a stricture to negotiate which is at an angle, then angled guide wires are helpful. But normally for straight cannulation, just use a normal straight guide wire. And right, okay. Two different ways of doing it. But then again, that doesn't mean you have to stick to one technique all the time. There's the touch versus non-touch technique. In the touch technique, you first advance the catheter, engage it into the papilla, and adjust your position into the CBD, and then advance your guide wire. Don't inject as yet. First the guide wire goes, then you inject, right? So whenever you try to cannulate, as you can see, your direct line is into the pancreatic duct. So if you go straight like that and pass a guide wire, you go into the pancreatic duct naturally, organically. That is your position. But to get into the CBD, you have to angle it up and slightly to the left towards 11 o'clock. So that will take you to the common bile duct. So that is the first, touch technique. In the non-touch technique,
sir, how can we get that position when we have a scope with us?
Yeah.
And you said that you will up the cannula and go to the left of the movement. How can we get this position outside?
Then you got the scope.
Yes.
You got the position. Your assistant has got the sphincterotome.
Yes.
They operate it for you. So you adjust it from your wheel and you do it from there, right? Because the sphincterotome is being operated by your assistant. And normally, nowadays we use the short guide wire, so we can control it ourselves because we use a locking system. Even in the short guide wire, I still use the old system of getting my assistant to do it for me. Some of the younger endoscopists, they use it themselves. I only use it in special cases if I have to do it. Otherwise, I ask my assistant to do it for me. Usually, they are very good. So this is the touch technique, yeah? So you do it through that. I prefer to use the non-touch technique in which I stick the guide wire out by half centimeter or centimeter, which is out of the catheter, and I engage the guide wire into the I find it less traumatic, I find it easier to cannulate, and it works for me. But then, having said that, in some of the papillas, if I can't do it like that, I just get the guide wire back to the tip of the cannula and use the touch technique. So it doesn't mean that if you are using the non-touch technique, you should never use the touch. Adjust it according to your needs. So there's nothing. Again, a lot of this depends on your skill and how you do it. Most of the time, we get the cannulation done within a minute or so, 1 or 2 attempts, maybe 3. Shouldn't take you long. Lekin, as sometimes luck would have it, even the most experienced person would struggle. So it's very difficult. Secondly, it depends a lot on the type of papilla you come across. I don't know if I've got, in my own set of slides, there are different types of papillas. Like there's the type 1, 2, 3, 4. They're the main ones. And type 1 is the standard papilla that we all see, common one, and that's easy to cannulate. 2 is the small papilla, which normally, allegedly, is more difficult to cannulate, but still, I never encountered any problem with that. Type 3 is the one which is always challenging, the one which is projecting, pendulous, floppy. And you can see it winking most of the time. So we usually tell our candidates, trainees, beware of the winking papilla. Because you think, oh, that's a piece of cake, it's such a big papilla. But those are the ones which are difficult. because they have got the CVD runs through that papilla in an over and under fashion. It runs in an S-shaped fashion. All right, okay. I think you got what you wanted to know. So this is the type 1 papilla. Too late. You got the. So ये type 1 papilla जो है ये standard जो आपको हमेशा नजर आता है. It's very common. ठीक है. So this is the one which is easy to cannulate. मतलब we shouldn't have any problem with it unless you are unlucky. Type 2 is the small papilla. Now, even if it's a small papilla, it doesn't mean that your wire wouldn't go through or your cannula wouldn't go through or your sphincterotome wouldn't go through. इसलिए अगर ये even if it is small, it doesn't mean that you should force anything through it. This will still accommodate your cannula, sphincterotome or wire. But because of its anatomical structure, it might be a bit more challenging to do it. But as I said earlier, I've never found it more difficult than the others. It usually works all right. The main problem is this one. This is always challenging, and this is because this is the shape of your जी हाँ, मैं बताता हूँ। इसमें जब आप गाइड वायर डालेंगे तो आपको गाइड वायर वैसे बहुत जरूरी है। तो ये गाइड वायर आपके यहाँ पे स्टार्ट हो जाता है। कैंडल डालेंगे तो कैंडल आपके यहाँ पे स्टार्ट हो जाता है। तो इट वुडंट गो। और आप कहते हैं कि पता नहीं क्या मुसीबत है, इतना आसान करते हैं और उनसे हो नहीं रहा। तो इसको करने के लिए नॉर्मली हम लोग ये करते हैं कि व्हेन वी ट्राई टू कैलकुलेट वी एंगल द टिप अप। ठीक है जी? इसमें to straighten this out you have to इस कर्व को स्ट्रेटन आउट करने के लिए आप इसको ऐसे खींचेंगे नीचे की तरफ। तो यू एंगल इट डाउन इंस्टेड ऑफ एंगलिंग इट अप। नॉर्मली आप जब कैलकुलेट करते हैं तो बार वक्त कैलकुलेशन के लिए आप उसको अब तरफ खींचना पड़ता है। आप जब इसको अब तरफ खींचते हैं तो उसका इफेक्ट होता है कि वो आपके टिप को आगे करते हैं, ऊपर करते हैं। ठीक है? इसमें आप स्कोप को अंदर डालेंगे। तो दिस विल स्ट्रेटन दिस आउट फॉर यू। जब स्कोप अंदर डालेंगे तो वो मतलब उसको खींचते हैं, अपने पीछे खींचते हैं। When you push the scope in, it pushes the tip back for you. So that will straighten this S out. उस situation में it will straighten it out and then the wire will go. Otherwise, you end up doing three
ये
quarters.
तो उस वक्त है ना जब आपका कैनुला एंगेज हो
हाँ।
प्रोट्रूडिंग जो तब्दील होता है उसमें कैनुला ही एंगेज नहीं होता सही तरीके से।
अभी तो फिर आप कुछ नहीं कर सकते ना, इसमें कैलकुलेट एंगेज करना होगा।
सर उसकी कोई स्पेशल टेक्निक है जो मतलब
नहीं वो कैलकुलेट एंगेज हो जाता है, दैट इज नॉट एन इशू, क्योंकि उस तरह कोई ऑब्स्ट्रक्शन कुछ नहीं होता। मेन जो है ना कैलकुलेट आपको यहाँ पे फंस जाता है। हाँ, तो दैट इज वेयर यहाँ तक तो आप कैलकुलेट वो कर सकते हैं, दैट नॉट एन इशू।
सर इसमें ऐसा तो नहीं कि हम लॉन्ग पोजीशन में हम
नहीं
जाएंगे
नहीं रॉन्ग नहीं होता ट्राई टू देखिए जो चीज़ आसानी से हो सकती है ना आप आसानी से करें इसका जो मेन बात है ये ना आपका कैलेंडर ये जो स्टॉक में कोई ऐसी बात नहीं है द मेन थिंग इज द टेक्निक ऑफ हाउ टू काउंटर इट काउंटर में यही होता है कि आप बजाय से कि टिप अप करें आप टिप डाउन करते हैं ताकि इसको आप खींच के स्ट्रेट करें एंड यूजली इससे काम हो जाता है तभी एडवांस की बात हो और अगर वो उससे भी ना हो तो देन आपको वो पुश करते हैं अंदर
पुश करते
तो उससे टिप आपका पीछे आ जाती है तो स्ट्रेट में विदाउट लेकिन यूजली टिप डाउन से आपका काम चल जाता है और आप उसको पकड़ के ना खींचते हैं पीछे की तरफ कैमरा को खींचते हैं
कैनुला को
हाँ कैमरा को खींचेंगे ना इट विल पुल दिस बैक so that is an important step to remember the S shaped
स्टेप
intra
खींचेंगे बट वाई एग्जैक्टली
जी
गुटका को ड्रॉ करेंगे बट वाई एग्जैक्टली
हाँ नहीं हमारा तो आपको ऑलरेडी टिप तक होगा ना तो जो ही आप इसको स्ट्रेट हम करेंगे ना जहाँ कैमरा को आप वो करेंगे तो वायर आप फिर एडवांस करेंगे तो मतलब ये है कि इट इज चैलेंजिंग बट इट वर्क्स
So advancement of this bone into the duodenal lumen will cause straightening of the
हाँ अगर आप स्कोप को एडवांस करेंगे तो देखें जब आपको आप शॉर्टन करते हैं ना अपने स्कोप को तो उसके बाद अगर आप स्कोप को और पीछे खींचते हैं ना तो दैट ब्रिंग द पेपिला क्लोजर टू योर स्कोप जब आप स्कोप को एडवांस करते हैं ना दैट टेक्स द पेपिला अवे फ्रॉम तो इस केस में आप स्कोप को एडवांस करेंगे ये बहुत कम ओकेजन है when you have to advance your scope. Normally you always pull your scope back ताकि पेपिला आपके करीब आए इस सिचुएशन दिस इज वन ऑफ द फ्यू सिचुएशन वेयर यू हैव टू पुश द स्कोप इन bring it straight. ठीक है तो ये मतलब दिस इज द मोस्ट चैलेंजिंग पेपिला टू वर्क दूसरा ये होता है कि इट्स अ बिट फ्लॉपी एज टाइप 3 जो है दिस इज योर नाइटमेयर ठीक है और ये फ्लॉपी भी होता है काफी तो इसमें आती है एंड अप डूइंग प्री कट और यू यूज दिस मैन्यूवर टू डू इट और फिर ये जो टाइप 4 जो होता है दैट इज बेसिकली वो होता है ग्रीज रिज ना इसमें जो इंट्रा CBD म्यूकोजा होता है दैट कम्स आउट तो यू सी दैट दिस इज देयर इज नथिंग टू इट इट्स जस्ट अ स्ट्रेट फॉरवर्ड पेपिला टू कैनुलेट इसमें कोई दिक्कत नहीं होती नहीं ये जो है ना इसमें ये इसके ज़्यादा पॉइंट में निकल आते हैं जो अंदर का जो नहीं होता ये इसमें थोड़ा सा नज़र आता है ना इसमें पूरा बाहर तक नज़र आता है बट दिस हैज गॉट नो इश्यूज ना मतलब यू कैन जस्ट इट्स जस्ट द शेप ऑफ द पेपिला कैनुलेशन में कोई प्रॉब्लम नहीं होता बट यू कैन जस्ट कैनुलेट इट स्ट्रेट
कुछ इलाज हैं जिनमें बाइल की फ्लो इज गुड बट देयर इज अ फ्लैश goes up into the lumen. So either to go above that flashing.
नहीं उसमें अबव की बात नहीं होती जहाँ पे आप कैनुला या उसको एंगेज करते हैं ना वो खुद ही अपना रास्ता निकालता है ना तो और या जहाँ पे आपको गाइड वायर जाता है ना जस्ट डू दैट क्योंकि इतना ज़्यादा इन्हांसमेंट आपको नहीं मिलती इमेज की कि आप वो देख सकते हैं कहाँ पे ORFS है या नहीं लेकिन मतलब यू कैन मेक आउट जनरली ना जनरली अप्रोच जो होता है आपका जो विद द ORFS होती है दैट इज मोर टुवर्ड्स 11 o'clock तो यू एम फॉर 11 o'clock एंड एंगल अप टुवर्ड द लेफ्ट मतलब कोई 11 o'clock इज अप टुवर्ड द लेफ्ट आपका जो पेनिट्रेटिव डक्ट होता है दैट इज मोर स्ट्रेट एंड टुवर्ड्स 3 o'clock
Can we pancreatic growth itself change this direction or position of
ये तो देखें ये तो हम आपको सारा जो है ना नॉर्मल का बता देंगे आपके जितने भी पेशेंट्स हैं या उनके पेपिलाज हैं दे डोंट रीड दिस क्लासिफिकेशन वो तो फिर जैसे कंडीशन होगा उसी तरह होगा ना तो उसके मुताबिक फिर आपको एडजस्ट करना होगा यू हैव टू मतलब ऑब्वियसली दिस इज़ व्हाट वी टेल यू इन द majority of the situation ना because in medicine anything whether it's ERCP colonoscopy every patient is unique so there would be some degree of secondly the other problem is whenever there is a stricture due to head of pancreas cancer, those are quite low-lying, and they can affect your cannulation because you have very little space to maneuver. आप fulcrum नहीं कर सकते उसको.
सर अभी हम लोग के पास ये ट्रेनिंग ऑन मैनिकिन का सेशन शुरू हो गया.
अच्छा ठीक है.
So should we go on that?
हाँ, we can. I'll just wind this up.
Okay.
ठीक है. चले मैं इनको ये डायवर्टिकुलम का बता दूं. Briefly about diverticulum. They are always a nuisance for a endoscopist, adding extra challenge. It's not such a problem if your papilla is on the edge of the diverticulum. ठीक है? जैसे यहाँ पे है ना, ठीक है? They are easily, cannulation काफी straightforward होती है. There's nothing here. The only issue is when you are doing a sphincterotomy, there's a higher risk of causing a perforation. And as Dr. Sarisha was explaining earlier, so much so that you should do a very small sphincterotomy and follow it up with a sphincteroplasty. Or even if you are worried, prophylactically you usually put a fully covered stent in. ताकि अगर कोई छोटी मोटी perforation हो भी तो you should cover it, right? The problem arises with the papilla which is inside the diverticulum. Those are more challenging. You can change your position, you can adjust your thing to bring your scope into position and try to cannulate from outside, लेकिन it is always challenging. उसमें ये कर सकते हैं कि there are a few options. One of the options is some people use injection submucosally. Saline या कुछ inject कर लेते हैं यहाँ पे this side पे, and that pushes the papillary orifice out for you, so you can cannulate it. I don't quite like that method क्योंकि उसमें ये होता है कि it's not all that effective and might close your orifice को compress कर देता है. The other option is, which I prefer to use, is that you can use a hemoclip, especially the bigger one, and deploy it somewhere around here, and जब उसको close करते हैं, so it pulls the papillary orifice out towards you, so then you can cannulate that, and that usually works. Sometimes you may.
एंगल पे लगाना है उसको जो
हाँ मतलब वो तो आप उस वक्त assess करते हो ना कि कहाँ बेस्ट है. तो उसमें हो सकता है बहुत आपको एक की बजाय दो लगाने पड़े, लेकिन उससे ये होता है कि it brings the papillary orifice into a more approachable position. हाँ, अब ये है कि जैसे बिल रॉड 2 या वो हो, गैस्ट्रेक्टमी हुई हो या रू एंड वाई सर्जरी, तो दैट इज़ a very challenging cannulation. We wouldn't expect you people to do it. You should always get somebody more experienced to refer them on to a major center. क्योंकि most of the time, अब तो खैर वो हम EUS assisted ERCP करते हैं, लेकिन in the past we used to do it, go down the gastroscope, check where the afferent and the efferent loops were, and identify the papilla, and most of the time I used to do it through a gastroscope. Normal front viewing gastroscope, we would do it, and I would do a sphincterotomy with a needle knife. लेकिन आजकल तो हम इस पे करते हैं, या EUS assisted करते हैं, और रू एंड वाई again is very challenging to do with an ordinary endoscope. या उसमें आप in the past we used to use enteroscope, इसके लिए स्पेशल होता था, लंबा स्कोप होता था, क्योंकि you have to go through a very long loop, or nowadays it's done through EUS assisted ERCP. हाँ, challenges में ये है कि factors that can cause swollen papillas are infiltration, tumor infiltration. That is one of the common ones. Whenever you get tumor outgrowing from the papilla, it might make it difficult for you to cannulate, लेकिन हो जाता है अक्सर, not totally contraindication. Obviously, different conditions जो हैं तो like if you got pancreatitis, you got other conditions which will make it swollen and difficult too. Or secondly, sometimes you do it yourself. बार-बार आप उसको probe करते हैं तो उससे it becomes swollen and damaged, and that makes life more difficult for you. हाँ जी, खेल खत्म।
Any questions?
पैसा खत्म।
ये अभी पैसा निकाल हम नहीं कराना अभी बहुत चीजें so tell me for you people how many times should you attempt before you can call for help? What do you normally do in your practice? If in a case of difficult cannulation,
Three attempts.
3 attempts.
2-3 attempts. सर हमारा सीनियर हमारे पीछे खड़े होते हैं.
So it's just the attempts or something else that makes you decide that you're going to refer to another
Proper
call for
attempt.
help?
Proper attempt. Properly attempt.
What is that proper attempt? That's what I want to know.
I try to cannulate the CBD or the ampulla.
So what do you think is most important when we're talking about cannulation? You've just done a dural intubation, right? So what's the first step that you do before you start for the cannulation? Position of the
Position and
Then?
observe the shape of the papilla.
What do you observe then? These are all things which are very bookish, right? Practically, how are you going to do it?
प्रैक्टिकली भी हम ये कर रहे हैं. पहले हमने लर्न की है वक्त के साथ साथ. पहले मैं एक स्क्रीनशॉट लेता हूँ, उसके फ्लोरोस्कोपी पे उसको अपनी स्कोप की पोजीशन को चेक करूँगा.
Okay.
उसके बाद मैं जो एम्पुला है उसको भी मैं प्रॉपर्ली ऑब्जर्व करता हूँ. इस फिंगरटॉप के साथ ऊपर नीचे करके उसकी
So
पोजीशन चेक
where do you
करता
want your papilla to be when you're looking at the endoscopy?
इसमें राइट इसमें मेन चीज ये होती है कि पोजीशन करने के बाद जो है हमें पेपिला को एक एग्जैक्ट पोजीशन पे रखना होगा.
What is that exact position?
लेफ्ट एटर पे जो है हमने 11 के साइड पे बनाना है. और हमारी जो कैनुलेशन होगी वो 3 o'clock से होगी. और उसके बाद जो है हमें पेपिला की स्टडी करनी होगी कि मतलब टाइप का पेपिला है और उसमें ट्रैक्ट किस तरह हमें जाना है. ये दो चीज़ें.
देखिए, जो किताबों में लिखो तो वो अच्छा होता है, कोई शक नहीं. लेकिन यू डू व्हाट यू सी प्रैक्टिस. एक मैंने जो शुरू में कहा था कि पर्टिकुलर पोजीशन शुड बी अनफास्ट. उसमें राइट क्वाड्रेंट होता है, लेफ्ट क्वाड्रेंट होता है. अनफास्ट मतलब होता है फेस वन. It should be in such a position कि आप जब कैनुलेशन करें तो आप अंदर की तरफ जाएं. That is from your basic position. लेकिन पेपिला अनफास्ट. अगर पेपिला को आप इधर रखेंगे तो मुश्किल हो जाता है. Then you have to go extreme. इधर रखेंगे तो फिर मतलब इधर जाना पड़ेगा. Keep it straight in front of you and then you select your position. More important. Secondly, जो भी procedure करें तो try not to complicate. Try the simplest approach to be possible. नरमी तरमीदे और वो ना उसकी जो करना है as simple as possible. दूसरा चक्कर ये होता है कि एक बात याद रखिए, जितने भी डेवलपमेंट हुए हैं over the last 30 years endoscopic procedures, in an endoscopy technique, in endoscopic equipment, the complication rate of the endoscopic procedures like the endoscopy OGD has come quite significantly. With ERCP has not changed despite all the advancements. With ERCP, you are in tiger territory. जो कुछ आप करते हैं, मतलब जैसे मैंने आपको पहले कहा था ना, मेरे साथ वो इनिशियल रिसर्च वो कहते हैं कि बिल्कुल इसकी जो रिस्क है वो यार लाइक ओपन कार्डिक सर्जरी ना, तो हम लोग तो खैर वी डोंट फील इट लाइक दैट, हमको that on देखना, लेकिन to him as an observer from outside it looked like that. So ये इसमें यहाँ.
Any questions regarding cannulation? Learned everything? You able to do it?
Even now when I do my procedures, after doing them for over 30 years, I still bring up my specialist nurse कि भाई वो कैसे मरीज next day. She rings them up कि भाई कैसे आपको कुछ हो जाता है.